Lung cancer is a leading cause of cancer deaths, and like all cancers, early detection is key to saving lives. A low-dose screening is what you need to detect lung cancer. It's a screening so easy, quick, and safe. We're going to show you one live just ahead. Good morning. Good morning. It's Monday, August 1st, and I'm Dr. Steve Stites standing in for Jessica Lovell today. We're in the Dolph C. Simons Jr. Family Broadcast Studio. A lot of words there. Thanks for joining us on Facebook, YouTube, and Twitter. COVID is not done with this yet. The BA.5 variant is dominating the metro and actually dominating the studio today. Dr. Dana Hawkinson joins us with the COVID count. Plus, it's World Lung Cancer Day, and the screening guidelines have changed, along with the average number of new cases. We have a great panel of experts to explain. They love all things lungs. I'm about to say they lung all things love, but I had that completely inverted. Pulmonologist Dr. Mario Castro, Vice Chair for Clinical Translational Research at the Kansas University Medical Center, and Critical Care Specialist and Division Director for Pulmonary and Critical Care. Lots of stuff there at the health system. He's a very smart guy. Dr. Joel Murmas, a great friend of mine, pulmonologist, critical care, CF doc. Joel has COVID, and so he is Zooming with us this morning. We're going to talk to him about how that came about. And joining us from Great Bend is family medicine physician Dr. Jonathan Pike. And of course, we have Doc Hawk here in the Hawk's Nest. And we have you at home. You play a big part in our discussion. Send us your questions for our team of experts. You'll find those links right here on your screen. Lung cancer is the second most common cancer in men and women, second to prostate and breast cancer. The American Cancer Society estimates that there will be more than 230,000 new cases of lung cancer this year. Let's turn to our guests. Doctors, those are really high numbers, but fewer cases than diagnosed last year. Dr. Murmas, why do you think there's a dip in the numbers? And first of all, Joel, how are you feeling?
Thanks for asking. I'm feeling okay, not too bad. Fortunately, my symptoms are pretty mild. As obviously you all know, I've been vaccinated and boosted, and as a result, I'm not feeling too bad. Just some mild sinus congestion. So. And
what was your vector? You told me this morning you thought it was your son. Is that right?
Well, every household has a Trojan horse, as they say. So, yeah, I'm afraid summer camp may got us. So that happens. But
well, we're glad you're feeling well enough to be on the program. Sorry you have COVID. Hang in there. We'll check in with you sometime this week here and make sure you're doing all right. So talk to us a little bit about the lung cancer numbers. Why do you think cancer cases are going down? Lung cancer cases are down a little bit.
Yeah, if you look at the lung cancer, the lung cancer rates of diagnosis, really over the last 20 years, they've been slowly declining, which is obviously great news. A lot of that, we believe, is probably related to reductions in the percentage of people that are smoking. And as a result, we're seeing less cases of lung cancer. So a lot of preventative measures, getting information out there about ways that we can prevent lung cancer seem to be having an impact as the rates are going down an average between 1% and 2% per year over the last 20 years or so.
Good news. And so while those numbers of lung cancer cases appear to have gone down, the guidelines for screening have also changed and are more stringent. The recommended age for screening has dropped from 55 to 50, and for smoking, 30-pack years to 20-pack years. So, Dr. Murmas, tell us a little bit, why are the guidelines a little more aggressive? What's changing there?
Yeah, so the new guidelines have taken into account a recent large meta-analysis that was done. That's essentially looking at a combination of a number of different trials. And in this particular analysis, they looked at up to 7 randomized controlled trials. And as I know you've discussed on this programming before, randomized controlled trials are really the standard of how effective is lung cancer screening. How effective is it at saving lives? And in this analysis of 7 trials, two big ones, one in Europe, one here in the United States, they found that roughly 1 in 320 people need to be screened for lung cancer with the screening technique we're going to talk about here shortly. in order to save a life. And that's if you screen for at least 6 years, a little over 6 years. You're going to save one life for every 320 or so people that you screen. And it was found that if that age was reduced to 50, and even for those who smoked a little bit less, in the pulmonary world, we talk about pack years. Pack year is basically essentially 1 pack year is smoking 1 pack of cigarettes for 1 day every day of the year. That would be 1 pack year. So for people who smoke 20 pack years now, when the guidelines used to be 30, people who smoke a little bit less also qualify, with the evidence showing that if we screen a little bit younger population and those who smoked a little bit less, that we're likely to save even more lives, is what the cumulative data showed, and thus the new guidelines reflect that.
So Dr. Castro, when we talk about screening, there are some basic principles of screening about how many do we have to do, what's the complication rate, because you can't screen everybody for everything. So why this?
Well, this is the best tool we have. Unfortunately, as we're going to talk about the symptoms of lung cancer, they're really not very specific. And so you need to have a screening tool that works effectively, and this does. And this is really the only screening tool we have, Steve, that will pick up a lung cancer, pick it up at an early stage that we can actually remove that lung cancer and potentially save a life, as Dr. Murmas mentioned.
Yeah, because I think chest x-ray, it has to be bigger, and by that point, it may have spread to other organs. Dr. Murmas, sometimes people without a history of smoking can get lung cancer as well. What's that about?
Yeah, unfortunately, a minority of lung cancer cases can be associated with other exposures. The number one other exposure, other than smoking, is radon. And most people have probably heard about radon. If you've purchased a home, your home inspector may have mentioned whether you want to have testing for radon. But basically, radon is a naturally occurring radioactive gas which can come from the breakdown of uranium, and it's possible that some homes and some buildings may have levels of radon gas in certain areas within the home that can leak through the foundation, or potentially other areas that can expose people to a radioactive substance, which can increase the risk of lung cancer. Fortunately, it's the minority of lung cancers that are associated with things other than smoking, which is something obviously that we can control and prevent. It's believed that 10 to 20,000 lung cancers in the United States per year are related to exposures other than smoking. So roughly 10 to 20% or less. The other would be, secondhand smoke would be the other primary exposure, which is also believed to be related to lung cancer diagnoses in people who didn't smoke.
Yeah, secondhand smoke, bad news. My parents are both smokers. Hopefully that's not going to get me someday. So Dr. Castro, the list of symptoms for lung cancer is really long. Chest pain that worsens with coughing, laughing or heavy breathing, coughing up blood, cough that doesn't go away, frequent infectious pneumonia, weight loss, loss of appetite, joint pain, bone pain, tiredness, all sorts of stuff. Do I need to wait for those symptoms to occur to get screened, or should I do that a lot sooner?
Well, I think that's the exciting thing about the availability of low-dose CT is that you don't have to wait for those symptoms, because we know when you present with those symptoms, often the cancer is too advanced. In fact, 60 to 70% of lung cancers, when we first detect them, are already in advanced stages. And so the idea behind low-dose CT is that when you're above 50 and when you're above those 20 pack years, as Dr. Murmas outlined, and this is something you don't have to necessarily calculate, but you can go on Google and Dr. Google can do it for you, or your primary care physician can calculate that for you.
Yeah, be careful of that Dr. Google stuff. You may get the wrong calculator on the Dr. Google.
Exactly. But once you meet those criteria, then you can be screened for the lung cancer screening program. And that really is the exciting part, because you don't have to wait for those symptoms. Those symptoms that are mentioned there, we see with pneumonia, we see with chronic bronchitis, we see it with our patients with emphysema and chronic lung disease. So it's not anything very specific to it. And in fact, when you get one of those scary ones like coughing up blood, that really brings to your attention. Often, again, that indicates that the cancer has spread inside the airways and is causing some bleeding. So let's not wait to that point. If you have a loved one that meets those criteria, greater than age 50, greater than 20 pack years of smoking, get them in to your doctor to do low-dose screening.
And those new CT scanners are pretty cool because it doesn't take much radiation. It goes super fast. It's not much longer than a chest x-ray. Dr. Christopher Pike is an outstanding family medicine physician in Great Bend who just got a new low-dose CT scanner or is getting one soon. What are the risks of low-dose screening? Why is it called low-dose, Chris?
Yeah, I'm still not the captain of the Enterprise, but I look forward to being that one day.
You do look good. I'm telling you, have you seen the new show? Strange New Worlds is awesome.
Yes. So, yeah, we just got the new low-dose CT scanner installed last week, and we're really excited about the opportunities now because, as Dr. Murmas and Dr. Castro have alluded to, with all of the symptoms, patients probably aren't going to show up, or they would show up with those symptoms, but people aren't going to show up to the pulmonology clinic and say, hey, I think I've smoked 15 pack years or 20 or 30 pack years. Let's get screened. I think that's the benefit of having primary care physicians involved in the process, because that's the job that we have, is the identification part. And so now that we have a CT scan locally that can aid to the screening process, we're really excited about that. So to answer your question, why is it called low-dose screening? It's about 1/7 of the dose of the radiation of a normal CT scan of the chest, and it's about 1/3 of the radiation that we get in background radiation just by living and breathing on planet Earth. So that makes it a lot safer for the patient. And when you compare it to the background and the other risk factors and harms of lung cancer screening, really it does not add, the scan itself is not adding extra risk to the patient. I would say probably some of the risks are finding other things that we didn't expect. And so what if we're checking for lung cancer and we find something else? And that's some of the risks that I would have to go through with the patient as I see if they're candidates for this. And then the other risk, I guess, some people don't want to know, and that's their choice. And if we find something, they wouldn't want to do anything about it. And so making sure they understand how each path plays out, if we screen it and what the treatments would be like, or if we screen and find something and they choose not to treat, what that would be. So that's where we stand here.
It's pretty cool. And yes, I know your full name is Dr. Jonathan Pike, but that doesn't fit my Star Trek mug. All right. All right, so we've learned the impact of low-dose screening for lung cancer as promised. We're going to show you how easy it is. Joining us from the medical pavilion here at the health system is Melissa Bullig, supervisor of CT radiology, and patient Bill Lyons. Melissa, Bill can't talk to us because you've been prepping him for the scan. Walk us through that, including the why and the how there.
So Bill is here for a CT scan of his lungs, and it's a pretty easy study. There is no prep for it. The patient just schedules their CT, and they come in, and the test itself takes about 3 minutes. Bill just has to lay here on the scan. He's going to go in and out of the machine about 3 times, and then we are done.
That's all. And does he have to even have an IV?
He does not have to have an IV.
No, see, that's like the best
without
scan.
contrast. The test is very fast. Yes.
All right. All right.
It's a
well,
fast
let's
one.
do it. Let's do it, and please give us the play-by-play happening while the screening is going on there. I think we could see Melissa getting ready. He's going to go into the scanner, and it's going to be really rapid. And Mario, is it true you can get something the size of a grain? You can find a grain of sand or something.
Yeah, I mean, this is amazing technology. Down to 1 millimeter, you can detect little nodules. And this part of the, I think as Dr. Pike mentioned, one of the issues about CT screening is we find so many other things, and we have to kind of monitor those. And so that's one of the things that physicians like Dr. Pike need to discuss with.
All right, so then the big challenge is you got to hold your breath in the scan. Having had a few CT scans before in my lifetime, I know that's it. Take a deep breath and hold it.
But that's what's amazing about this technology now. It's so fast. It's a single breath.
Yeah.
So it is 6 seconds. You know, it's literally, it just goes like that.
You can see how fast the whole day thing's going.
Start breathing.
Melissa, you doing, and Bill's doing okay there in the scanner?
He is.
Excellent. So, Dr. Mervis or Dr. Castro, tell us the role of this background smoking or passive smoking, whatever we want to call it. Talk to us a little bit about the role of that in lung cancer.
Well, we know either primary smoking, somebody smokes themselves, or being exposed to somebody secondhand
Please breathe
smoke.
in and hold your breath.
That smoke exposure has a number of carcinogens, and so those activate cells that in your body can turn into lung cancer.
Start breathing.
And it can start at a very early stage without you knowing about it, and as that grows, then that starts to press on other structures in your body or start to erode, and it causes the symptoms that we talked about earlier. But the problem, Steve, is that this has to get to a size to do that, and what we want to do is detect it with this low-dose scanner, just like Bill's having done there, at that stage where it's just less than a centimeter in size, so we can then go in there and remove it.
And it looks like, Melissa, is Bill done?
Bill is all done. It's easy as that.
Wow, that was
You
like
are
really
done.
fast.
You're done and free to go.
Great.
All right, Bill, thank you for
I'll
being
show
on
you
the
the way.
program.
Let you grab all your stuff.
Not one of those.
All right.
A lot easier than a colonoscopy, I would
What's
say.
that?
That's a lot easier than colonoscopies. And because
More fun.
yeah, more fun, that's right. And hopefully he's going to get good news from that scan. Jill, I bet we have some questions from our viewers popping up this morning. What do you got? Uh-oh.
Bottom line, what does this cost for those without insurance? If we don't know that answer, I'm sure we can find it, but does anyone perhaps know?
I don't know that off the top of my head, but we will find out. Most insurances now cover it, I think, though, right? I think Dr. Mermis or Dr. Castro, I think it's usually covered because it's become standard of care. If you don't have insurance, you want to pay for it on your own, we'll find that and get that to you later this week. I'll be back Wednesday. Let's see if we can get it by then.
Okay, we'll do that too. And then Cindy is asking if a low-dose CT scan can be used for anything other than lung cancer.
Ooh, great question. What do you think, Dr. Castro?
Yeah, so I use it every day. In fact, this is the preferred therapy or preferred imaging technique that's going to be part of the future. We believe as this technology gets better and better, faster, lower doses of radiation, it will replace the plain chest X-ray, which is kind of what we've been working with for a number of centuries. Well, not centuries,
Be careful.
decades at least.
Be careful there, brother. I've been working for a long time.
But this technology helps us detect other things. As mentioned by Dr. Pike at the beginning, I've had patients screening for this, and we found out, well, they have pulmonary fibrosis or they have scarring in the lung. And I found that they have other conditions like calcification in the coronary arteries, which is a sign that we use for detecting early heart disease. So there are so many other advantages to it.
Dr. Castro, our doctor, I said that, I meant Mermis. Dr. Mermis, you and I use it in cystic fibrosis patients. Sometimes even with airway infections, you can tell patterns of infection. Talk to us a little bit about that.
Yeah, that's right. And I think it's important to clarify, this lung cancer screening program, the technology, the software for the CT is very specific for detection of lung cancer. Often when you'll see your doctor in clinic, whether it be your primary care physician or a pulmonologist, for example, they may order a dedicated CT chest looking for something else specific, which is really, I think, what we're talking about. Although, as Dr. Castro mentioned, it's not uncommon for us to find other unexpected things or diagnoses on the low-dose lung cancer screening CT. But yes, for example, other people with other lung conditions will use this same technology frequently to help get a better characterization of the severity of their disease, whether their disease is advancing over time, or whether they're responding to the therapies that we're using. For example, in cystic fibrosis, we often have people on various treatments to help improve their lung disease, improve the chronic lung infection that people with cystic fibrosis suffer from. And CT is a great tool for us to be able to see if those therapies are working as we anticipate that they should.
Jill, other questions?
Yeah, first though, I want to give a shout out to our really amazing web team. They did find an answer. I know it doesn't speak to the cash, but it says Medicare and many other commercial payers have approved this screening as a covered benefit for those who meet high-risk criteria. For those with insurance, we will bill your insurance provider if you need further tests. It says that the insurance companies will additionally pick up those as well. So it sounds like this is a great test to go ahead and get. And then Lisa, I think we may have talked about it, but she was saying, could you go or answer one more time if there are any risks associated with low-dose lung screening?
You know, the risks are pretty low, Mario, because the background radiation, the radiation from this is so much reduced from a standard CT.
Yeah, so I think Dr. Pike mentioned that about a third of kind of the natural background radiation that you just going outside in the sun, you're getting a little UV radiation. So it's truly gotten that down to the point that this is pretty much like almost like getting about 10 chest X-rays, in terms of that radiation exposure, and it's really I think something that you have to weigh with your doctor. We're not going to do it in everybody because it does have some risk involved with it. By the time you meet those criteria, though, 20 pack years of smoking and at least 50 years of age, your risk is much greater at that point than this really low dose risk of using a low dose scanner.
And just to say, vaping is not safer than smoking.
Correct.
All right.
For many reasons.
Yeah, for many reasons, and maybe worse in many ways too. Jill.
Yes, let's take one more, and then we have more coming in, but I'll save them because I know some people are interested in the COVID count. But Brian and Brenda are asking, is lung cancer hereditary?
Ooh, Dr. Murmas, I don't think it's necessarily hereditary, although you can have a predisposition or predilection.
Yeah, that's right. There is, definitely some individuals who are diagnosed with lung cancer who don't have any clear exposure risk that we can identify, who probably do have some genetic predisposition. Although at this point, identifying what that specific predisposition may be and tracking that back in families at this point is can be difficult to do. But for some rare cases, there may be some genetic predisposition for some individuals.
Yeah, but the overwhelming thing is smoking,
Yep.
and smoking. Dr. Pike, are your patients, are they good with the low-dose CT scanner out there in Great Bend, or how's that going so far?
Well, this is the first opportunity that I've been able to discuss with patients that we actually have it now. So for probably about the past 6 months, where I knew we had it slated to get, but this was one of the other many downsides of COVID is that it pushed back our CT scan arrival date. But looking at the patients that meet the screening criteria and prepping them to say that this is an opportunity that we have coming soon. And I think just with so many other people suffering from lung cancer and them seeing what family members or friends have gone through with that they are really eager to engage in the possibility. And I think one of the other ways that this really helps me on the front lines is to prompt them for smoking cessation if they haven't quit already. And looking at some of the research and studies, people who are willing to participate in this program have at least a 15% better smoking cessation rate and adherence to that smoking cessation without relapse. So this is going to be a great tool, not just from the screening purposes, but from facilitating smoking cessation in many of my patients.
Well, I like that. That would be great news. All right, it's time to check in with Dr. Dana Hawkinson, Medical Director of Infection Prevention Control, infectious disease physician, to learn about our COVID count today. Doc Hawk, how we do?
Yeah. I think we're still doing good, better than the last couple weeks. Certainly we still have quite a few patients in the hospital, 28 active, 4 in the ICU, 2 of those on the ventilator, still 16 in that recovery period, Steve, but again, probably down about 10 active infections. from where we were, at the beginning of last week and that week before that. So I think that hopefully then is a good trend, and that's what we've been waiting for, is really to look at that 7 to 10 day trend.
We sure hope that's right. And the numbers are down. Hopefully the numbers are going to continue to go down, because across the country, it sort of depends on what region you're in.
Absolutely.
You're seeing some spikes. If we could pop up that New York Times map, the hotspots. There are a few new hotspots that have emerged around the country, and you can see it again in the southeast, the southwest. Not so much the northeast, I think they've had there, but it's in the Midwest and the Ohio Valley area. But still a lot of hotspots throughout the country, and we're still in the red zone here in Johnson, Wyandotte, Jackson, and Clay.
Yeah, and it really is unfortunate. Again, I think we, as a nation, kind of reached our most recent nadir at the end of March. Since that time, we saw a fairly steep curve. If you look at any of the national cases curves, we saw a fairly steep curve, but it seemed to plateau. It's really staying in that plateau, up or down a few percentage points every week. But unfortunately, if you look at hospitalizations, that has continued to have a slow increase, and I think that's what we have been seeing, and we certainly saw that and are seeing it here at our health system.
So breaking over the weekend, President Biden tests positive again for rebound COVID after he took his Paxlavid.
Yeah.
We're seeing that.
Yeah, again, I don't understand if he had symptoms again or if they were testing him out of precaution.
He was asymptomatic and they were testing out of precaution.
So, again, I think this sends a confusing message, just as does Dr. Fauci taking that second course of Paxlovid. Again, second course of Paxlovid is not in the EUA. Certainly, I'm willing to monitor and have those clinical trials for longer courses or a second course. But this is just, I think, sends a confusing message. However, we understand President Biden has to meet with people and is all around. This is probably out of more precaution than anything. He did go back into isolation.
Yes, and it's interesting to note that, remember, Paxlovid was really looked at most closely in the unvaccinated population.
Absolutely.
We're using it in the vaccinated population, and I think appropriately, especially when people are older and have more other risk factors.
Yep.
But the truth is, we never really studied it that thoroughly in the fully immunized population.
Yeah, I think that is a great point. It is really to help reduce your chance of hospitalization, and the greatest benefit came from those that were in the study trials that were unvaccinated. Very minimal benefit for those that are vaccinated and up to date. And especially, like you said, Steve, I think we always have to consider in this talk about COVID and hospitalization and death, comorbidities or things such as age, because those are vitally important as well. Okay,
so should anybody get Paxlovid right now, or should it just be reserved for those, especially vaccinated, that you maybe have more risks?
Yeah, I think I know with what we know about the bulk of the evidence continues to support the fact that really if you are unvaccinated, if you are otherwise young, say under 50, up to date with your booster, I don't really think that the benefit is very good, that there is much benefit of taking Paxlovid. It may help with your symptoms. But again, we have people who really don't want to take medicines. I think this would support the fact that if you are otherwise healthy, up to date with your vaccines and boosters, you have coronavirus, you probably do not need Paxlovid in that situation.
Yeah. So there's an immunologist that's warning that a new strain of COVID-19 could be causing different symptoms. Is that BA.5? And what's this about it emerging at night?
Yeah, again, I think this is anecdotal. This is out of the UK. It's hard to really understand and digest and tease these things out now with so many people vaccinated. We really need to do a very good study to understand this and look at this. Are those symptoms due to vaccination and your immune system actually getting kicked into high gear because now you're seeing the virus? We know that people are said to be having symptoms earlier. Most of that is probably because they have been vaccinated, so their immune system is start working. That is what's causing the symptoms. This may be a consequence of that as well. Again, I think it's an interesting observation, but definitely needs more study.
So we've learned over the pandemic how devastating COVID can be on our lungs. I may be biased, but I think it's pretty clear that's one of the primary organs we have to worry about. I have to ask this panel of experts about their patients, how COVID's impacting them. Dr. Murmas, how about you? You're with our CF patient population or other groups. Have they been affected? Don't forget to unmute there, Joel. There you go.
Oh, can you guys hear me? I'm unmuted, but you hear me okay?
Yep. Mm-hmm.
Okay.
Gotcha.
Sorry about that. All righty. Yeah, when COVID first, when the pandemic first started, we were very concerned about, people with CF, population of people that have pre-existing lung disease, with concern that they would really be at risk. Fortunately, I think two things really benefited that the majority of that patient population. One, as you know, a new therapy for CF fortunately became available and was FDA approved in 2019, which really changed the landscape and helped people through this time do so much better with their baseline CF disease, which we really believe has had a profound impact on their ability to get through COVID infection, to where the majority of people fortunately have done well. The other main advantage is that most people, not all, but most people with CF are pretty young. And as we've seen throughout the pandemic, most young people without a lot of the risk factors for severe COVID, which we otherwise know of, being a predominant one. So the majority of people have fared well, fortunately, have had mild symptoms. And of course, we've really worked hard to promote vaccination among this population to help protect them. Even with all of those efforts, like I said, most people have done well, but we have had a few cases where people have developed severe symptoms, required hospitalization. Fortunately, that's been a small minority of people, but we've had some, unusual cases. The as expected respiratory failure that can occur. Generally, this occurs in people with very advanced lung disease, or those, as you well know, post-lung transplantation, who are on immunosuppression and for this reason aren't able to respond to the vaccine, as well as someone who's not on immunosuppression and thus puts them in a high risk category. We've also seen people with other manifestations of COVID as have been published, such as issues with thrombotic issues or clotting and the complications of blood clotting, some rare instances of that affecting their health. But the overall message is that most people with CF fortunately have done well because of vaccination and because of the pre-existing advances in the treatment of CF. We're very thankful that was developed just prior to the onset of the pandemic.
Yeah, that was a really lucky thing. So, hey, Dr. Pike, have any of your patients suffered chronic lung disease or damage from COVID that you've been taking care of?
Yes, I do have a handful of patients on my primary care panel that I think most of them were really affected by the Delta strain. That's the one that I've seen anecdotally hit the hardest. And those were the people that required, even some young people that required stay in long-term care facilities before they came back to me. The other, not necessarily chronic, but long-term manifestation that I've seen also most notably from when Delta was surging was people that had some pulmonary emboli and blood clots in their lungs and following them up for the 3 to 6 months after that. But those are the two biggest things. And now we have a fair number of people who are by age in the higher risk population that are getting Paxlavid, but I don't see them in the clinic very much, and we haven't had any hospitalizations for a while, which we're very grateful for.
Yeah, Paxlavid's been a game changer in this disease. Dr. Castro, you've been engaged in research around COVID throughout the pandemic. What have you learned that might be of a special note to our audience?
Well, I think as we talk about the current state of COVID, we know that one of the biggest problems we're going to be facing in the future, Steve, is really the sequelae. What's going to happen after all these cases of COVID. And even with mild cases, we know that you can develop long-term sequelae of that. We call that long haulers or long COVID. And we're trying to figure out what to do with that. And so we are enrolling patients in a RECOVER trial. There are 17,000 patients to be enrolled in that trial. Over half of those patients have been enrolled so far. And in fact, here at KU, we're one of the top enrollers into that study nationwide, which is really nice. We're trying to learn. We're trying to learn what are the appropriate diagnostic tests, what are the syndromes or the cluster of symptoms that we're seeing and what causes that, and then we're starting to set up clinical trials. And in fact, we're hoping to participate in those clinical trials yet this fall to try to treat that. So that's where we're at in terms of understanding the long COVID, but I really think that one thing I want to ask, which Dr. Murmurs brought up, is some of these immunosuppressed patients, what is the status, Dr. Hawkeye, about the monoclonal antibody?
Yeah, so currently there is that one monoclonal antibody that we use as therapy. This is therapy for acute infection, bebtelovimab. It seems to still have activity. It is alternative therapy. Again, the preferred outpatient therapy is continues to be Paxlavid. We continue to give bebtelovimab to those patients. And again, that's that monoclonal antibody to those patients that could not receive Paxlavid or don't want to get it, who are at high risk of hospitalization. It does continue to protect and have effectiveness against BA.5 and what we've seen through Omicron and its subvariants.
So no role in prevention or with transplant patients?
No, not for that monoclonal antibody. We do have Evusheld, which is for patients who are unable to take the vaccine or for patients who you believe will not have an immune response to the vaccine because of high-risk situations such as chemotherapy or other immune dysfunction. That does continue to provide very good protection and prophylaxis against infection as well.
And your asthma patients, how are they doing with COVID?
They're similar to what Dr. Murmas mentioned with our CF patients. They're doing pretty well. We know that asthma is a very common disease. When we've looked at patients that ended up in the hospital with COVID, it appears pretty close to what the population risks are.
You know, and I know in the lung transplant population that the impact of COVID and Omicron in particular and BA.5 as part of that have been especially severe. And unfortunately, that group is not a candidate for Paxlovid because of drug-drug interactions. And so you're really left with, hopefully they've been vaccinated, gotten the Evusheld, which they're supposed to get every 6 to 12 months, and then some of these monoclonal antibodies, remdesivir and other things, if they come in the hospital. Hey, let's get back to our topic about low-dose scan and detecting cancer. What's going to happen next in this whole world? How do we treat lung cancer, and how has that changed over the recent years, Dr. Murmas?
Well, I think the main message here is that, as has been the case with many advances in the treatment of specific diseases, this is also true for treatment of lung cancer in that it's become very personalized. And, personalized therapy basically means that we're able to take the total amount of information at the time of diagnosis, that being, what kind of gene mutations specifically are within the cancer that an individual has, and what other factors may be relevant, whether they smoked or had other exposures. That total amount of information, including the gene mutations that they have within their cancer, can be used to then tailor a very specific therapy for that individual, so-called personalized medicine. And we continue to see advancements in personalized medicine that have dramatically improved the overall mortality rates in various cancers, including lung cancer.
Dr. Castro, there are a lot of trials out there around lung cancer. What do we have going on now, and are you excited for the treatment of lung cancer?
Yeah, I mean, I actually I was thinking, in my training, if I was going into a subspecialty right now, this might be the area because this is really going to change. When we first started a few years ago, Steve,
yes,
lung cancer was one of those things that was very tough because things weren't improving, but now things are radically changing. There is, I'm going to refer you to the KU Cancer Center website. If you'd like to participate in a lung cancer trial, there are a number of them going on right now. We have some of the outstanding leaders in the field, Dr. June Zhang, Dr. Wan, are leading some of our lung cancer trials here. And they're using this as Dr. Murmas mentioned, it's targeted therapy. We've learned a little bit from breast cancer that if you take a little piece of the tissue and you figure out what mutation is inside that tissue, then you can actually target that lung cancer itself with specific therapy. So there have been KRAS mutations that have been targeted as well as other things. We also have immunotherapy that has now been developed for lung cancer. Very exciting because it could potentially, if you have the right type of lung cancer, can really change your outlook in life.
Well, I'm sorry, go ahead.
Yes.
I was going to say, as a person who has I lost my mom when I was very young. I was 19 when she died from lung cancer from smoking. And this is near and dear to my heart. And just cancer therapy in general, and lung cancer in specifically, is rapidly evolving, and what a tremendous move forward that is. If you're interested in learning more about that, there's a link up at the top of the screen there that you can grab on that will take you to the Cancer Center, and you can become involved and if you're interested in more about that. So Jill, let's see if we have any reporter or community questions out there today.
We've got monkeypox, COVID, and low-dose CT questions. One that I have for you is you mentioned about your mom. Do you get low-dose screenings?
You know, I haven't yet. I'm listening to the program. I'm a lifelong non-smoker, however, pretty adamantly so, actually. But I did have a lot of secondary smoke when I was young, so I should ask these guys, should I get a cancer screening? Murmus? This is your chance to punish me.
For the, I think, you know, if we were to adhere to the guidelines, which we generally recommend doing, you would not qualify unless we thought you had, as we discussed earlier, a 20 pack year exposure over the course of your lifetime. And then also, I don't know if we discussed this, but also people need to have quit smoking less than 15 years prior to initiating the screening. So in your case, I would presume it's been more than 15 years. So at this point, you probably wouldn't qualify.
Yeah, you're right. I've never smoked, so it's been more than 15 years since I haven't smoked. So there you go. All right.
John wants to know if the Proton Therapy Center that recently opened, if proton beam would be used to treat lung cancer.
I don't know. I saw that question. I'm not sure I know the answer. Do you guys thoughts?
Yeah, no, currently proton therapy is not utilized for the treatment of lung cancer, but radiation therapy certainly is, and is can be a life changer. I've had some patients, Steve, that have had pretty advanced lung disease, emphysema, and they can now use those stereotractic, computerized radiation beams to really just target to a very small piece of the lung and treat that part. So radiation is definitely part of it, but not proton therapy at this point.
Ying Lang would like to know, how high is the false positive rate that might result from a low-dose CT in detecting lung cancer?
Well, that's a good question, Joel, because really you're trying to look for the mass, or you're trying to find that little area that looks a little suspicious, and after that you have to go get a diagnosis. So it's a screening tool. It doesn't actually tell you that you have cancer, so I'm not sure false positive rate. That's a kind of funny question on that.
Yeah,
Sorry.
Oh, sorry. Yeah.
Go ahead, Joel.
Yeah, I was just going to say it's a relevant thing to talk about, because we often do have, the typical scenario would be that we find a lung nodule, which is a small spot within your lungs, and then we have to determine how do we approach that? Do we need to get a biopsy, or should we just monitor that with a sooner CT scan than the annual low-dose CT scan? So, it's important to, when we talk about this, as Dr. Pike mentioned, to talk to our patients about the fact that it may result in potentially a biopsy of something that is determined later to be benign, or additional CT scanning, because we're monitoring a spot very closely to make sure it's not changing.
Yeah.
Okay, one more scan question, and then we'll move to monkeypox and on to COVID. Lindsay wants to know, if you have a cardio scan at KU, does it pick up the lungs as part of the scan, or is that a different test?
I think that's a different test.
It is a different test. In fact, for the cardiac scan, which they're trying to pick up calcium in the coronary arteries, it's focal and localized around the heart. So we do capture a little bit of the lung that's surrounding, but it is not an adequate screening test for lung cancer.
It doesn't get to the periphery of the lung, although sometimes you do see some interesting things inside the lung that makes you go do more work, but really it's not a good screening test for lung cancer.
I lied. Rhonda just put in a good question. She says, what if a person smokes cannabis daily? Is there a potential lung cancer concern?
Yes.
Yes.
Yes. Because, and partly that is, it's the combustion that you're going to inhale, and so the reality is it is. If you're going to vape all the time, that's a lung cancer concern. It's a simple rule, actually. Your lungs don't like smoke or stuff that you inhale of any substance, and as a result, they can all cause problems with cancer. So I would just say the best therapy here is to just say no.
And I'd like to bring in some infectious disease too.
Please.
We know and understand with cannabis, with flower smoking, you can also have risk of Aspergillus infection, and we have seen that here at our health system, especially in those people that are maybe immunosuppressed now because they're on chemotherapy or things like that. Aspergillus is a common fungus found in the environment, found on plants, and so when you inhale that, it doesn't really get burned or killed by the heat of that joint or whatever you might be smoking. So you have infection risk there as well.
And Dr. Pike, because I remember when you and I first met a few years ago, you had hair on the top of your head and not on the bottom of your chin. There's no chance that cannabis or smoking had any contribution to that, right?
I am a lifetime, like you, I'm a lifetime non-smoker, and there is no cannabis contribution to this either.
All right, excellent. Jill.
Isaac wants to know that in July, it was said that N95s and respirators were required for the care of monkeypox patients. And that monkeypox could be spread in respiratory droplets. So why aren't we masking for monkeypox?
Well, it could be spread in respiratory droplets,
Yes.
Hawk, but it takes like 3 hours.
Yes, you had a very good explanation of this. I think that's a great question. We will be using care for any monkeypox patients here in the health system with N95 or respirators. That's absolutely correct. You can spread it on respiratory droplets. It certainly can be spread, but just as Dr. Stites said, it is much more difficult to spread it that way. You do need much more time, much closer contact as well. It is not spread really in that same vein as SARS-CoV-2 is when we're thinking about respiratory droplets, and so I would agree with you, Steve.
Yeah, it takes 3 hours,
that's a
not
good
3
question.
minutes. Yeah, it is a great question. Jill.
Ying Lang is wanting to know, what is causing the surge of monkeypox cases in New York?
Well, what I can tell you for sure is that of the, I don't know, is it 8,000 now or so cases in the world, and I think the U.S. is up to almost 5,000 maybe. I'm not.
We report it so darn much.
Yeah, I'm not clear on that. But what I think we need to continue to say is that 98% or more of those current patients that we have seen it, especially in the United States, are really, it is that men who have sex with men group, and we want to continue to put that information out there for everybody to be safe. It is through a lot of social networks like that, anonymous interactions with each other. That is the main way that this is starting to be spread, and so we really need to continue to get that information out for everybody to understand, what are the actions that you're doing, understand the people that you're doing them with, understand your risk of doing that. So that is what we are seeing, and that is the same thing in New York as well. And we know that San Francisco and New York has really risen the alarm about that and really tried to get that information out there to keep everybody healthy. We are trying to do that as well. Understand that really the mode and spread of this disease is really through that close, intimate contact, that skin-to-skin contact, but also clothing and bedding and other things that may have some of that drainage from some of those pustules on it.
Do we offer the vaccine here?
Right now, we do not. So we know that Health and Human Services, the Biden administration is rolling out vaccine to the states. The supply is getting better, but right now, vaccination in Kansas is really through KDHE. But we are working on that. Hopefully, there will be easier access towards that.
Jill.
Yeah, let's wrap up with a few COVID questions. Jean wants to know, what do you know about the report that having COVID negatively affects the length of your life expectancy?
Well, we know that to be
Yeah,
true
that's
because
absolutely true.
A, there's a lot of death associated with it. B, there is long COVID and other chronic syndromes, so life expectancy does go down. That's
Yeah.
kind of a statistical exercise.
Yeah, I think that is completely true, and we have seen that since the pandemic. There has been a number of epidemiologic studies, and it truly does. We have seen the overall life expectancy go down during the pandemic, but even more, Steve, which you have really tried to champion and talk about a lot, we have continued to see more social injustice during that pandemic as well, especially around COVID and all of those things. So there are quite a few intricate details about all of this, but certainly we know that COVID and the pandemic in general has decreased life expectancy.
Yeah, and people ask why, if you have more economically challenging circumstances.
Yep.
First of all, you're in an environment sometimes where people are living closer together. It's easier to transmit. Second of all, you got to go to work, and you can't Zoom, and you're trying. And so there are, and then if you lose your ability to be employed or you lose income, all of those things contribute, Mario, to a more difficult outcome for this country around COVID.
Yeah, and I think it's not just economics; it's also access. If you we were very interested in participating in the long COVID study because of our access to rural populations here in the state of Kansas and Missouri. And what we found out was that if you came from certain regions, rural regions here in the state of Kansas, your risk of dying from COVID was 3 times higher than from urban areas. That's pretty striking, and that is certainly something that is a risk factor that we have started to recognize. It's not only socioeconomics, but it's also that access to care.
Makes a difference.
That's why we need Dr. Pike over there.
That's right, Dr. Pike out there taking good care of our patients out there in Great Bend.
Joellen is asking, what medicine do you have to stop taking if you go on Paxlavid?
You know, you really don't. I think you need to talk with your medical provider who's ever ordering that drug for you. Even in those patients who are immunosuppressed, so we have a lot of concerns about our transplant patients who are on immunosuppression because some of those drug-drug interactions. However, just understand that these are somewhat theoretical risks, but also understand the Paxlovid is for a very short period of time. So just talk with your medical team, those pharmacists that are helping with that. You may have to reduce those risks, but you really shouldn't have to alter your medication regimen in general. Again, this is a very specific question for you as an individual, but in general, you shouldn't really have to stop too much. And again, it's a short course of therapy. It really should not impact anything too significantly, but just talk with your medical team.
And Gene wanted to clarify, he was talking about survivors of COVID, whether you have a mild or a strong case. Does it impact how long I might live?
Okay, that was more of a question. Yeah.
I think it still does. We continue to see decrease in life expectancy. It does, but it can also affect your quality of life, just as Dr. Castro talked about with long COVID and things of that nature, but also increasing your risk of other problems as well. We know that it can increase your risk of stroke later on. It can increase your risk of heart disease. A recent published study in JAMA, the JAMA network, also showed that those people that were vaccinated did much better, had less risk of things like ischemic stroke and heart attack if they were vaccinated. But those people that were unvaccinated had higher rates. So even vaccination, I want to pull that back in as well. Vaccination will help reduce those chances of having those complications as well.
So at the end of the day, COVID is a bad disease, and you need to get vaccinated to stay safe from the disease. And when there's a higher amount of COVID, you ought to take more precautions.
Yeah.
Okay.
Jill, that sounds like brand new. We've never said that before.
Right. 2 questions on COVID and 1 lung question that just came in that I'm curious about, and then we got to cut it off. Kathy wants to know, do you think someone is no longer contagious if they still test positive 2 weeks later from taking Paxlavid?
You know, generally that just means you're shedding virus and you're not positive, unless you've got a really severe immunosuppressive illness, in which case you may still shed virus.
Yeah, I think let's take the immunosuppressed out of it, Steve, because you bring up a very good point. So the people, and I'm going to assume this question means if you are non-immunosuppressed, because I think we have to consider that. That's a very good point from you. Yeah, I think that the Biden issue really confused things.
And Fauci as well.
Right, and Fauci as well with the rebound and then taking it again. But I think in general, and there are a lot of stories about this right now in the news media also. In general, what we know and understand is that you really should not be testing again. The CDC guidelines say don't test again. You can test, it is certainly in there as a possibility to do, but really after about those 10 days, you should not be shedding any infectious virus at that point in time. So I understand this question. I think all these questions today have been really on point and insightful. But really after that 10 days after that symptom onset, you shouldn't be shedding any more live virus. You should not really be testing again. The general public doesn't really need to be testing again. That's currently not in the guidance. Obviously you can, but you shouldn't be shedding live infectious virus, especially at that 2-week time point, just like was in the question.
And remember that you don't test for live virus when you do your home test or your nasal PCR. You're testing for viral particles, different kinds. And the answer is that you may well shed virus for weeks.
Yeah, and I think that's a good point. Now, PCR, we know you can be it can be very sensitive and pick up just pieces of that RNA. Some people will say, well, if you are antigen positive, you are creating enough virus to be spread to other people. But however, again, there's not a lot of recommendation to be doing that. And so I think after that 14 days, after that situation that we heard about in the question, you really shouldn't be shedding live virus at that point.
Judy says that her husband has had COVID twice. Sorry to hear that.
Yeah.
She has long COVID question. He seems to have lost some of his temperature regulation ability. He's always cold now. Very obvious change. Is this common? And the last time he caught COVID was a year ago.
You know, we're seeing that, Hawkeye. I'm seeing some of my patients as well. Lots of long-term changes. And I think, Mario, you mentioned this earlier. Yet another problem we're seeing with long COVID is that loss of temperature regulation. You just don't feel right.
Yeah, that's correct. I mean, we classify this under the autonomic dysfunction that can occur with long COVID, which means that there can be changes in how your body is sensing things in terms of temperature, nerve sensation, how your blood pressure fluctuates when you stand up, and lightheadedness that can occur. So this is exactly some of the things that we're testing for in the Recover study, is trying to figure out what's the appropriate test from your doctor, and then what can we do about it.
Okay, and my final COVID question, I'm sorry. Kathy, she wants to get a second booster, but she got sick. And so she's like, I'm scared to get it. What would you tell her?
You know, Hawkeye, you should still get that second booster.
Absolutely.
You wait your 6 months and get it, and you may be sick for a day, and after that you bounce back pretty fast.
Yeah, absolutely. Did she get COVID? Is that what the question was, Jill?
No, she got the COVID booster, I think.
She got the booster, and it made her
Oh.
sick.
Okay. Yeah,
And she wants to
absolutely.
get another one, but she's afraid.
Yeah, and what we have seen is that people who get the first series, even the first shot, their reaction may be different than with the second shot. That reaction can even be different with the third, which will be the first booster, or the second. So just because you had reactions to one or two of the other doses doesn't mean you're going to have those same. We've seen discontinuity as far as people who get symptoms after their doses. I would much prefer, 24, 48 hours of some fevers or chills or something like that compared to the risk of actually getting the infection itself.
And the long-term things to code, which we just heard from the prior viewer, who lost temperature control or taste or
I understand that concern,
issues,
and I think it's valid, but go ahead and get that booster.
Okay, Sandra gets the last question, and it is a lung cancer question, and I don't know if I can say it, but why is 3B lung adenocarcinoma treatable but not curable? I think she's saying that she's seen people live with it for 10 years.
Yeah, Murmis, that this whole staging of lung cancer, it does impact. I mean, 3B is a little harder to treat than 3A, but people could still survive.
Yeah, that's right. I think this really, this really goes back to why lung cancer screening is so important. So if we detect the lung cancer early, like we talked about, where we're finding lung cancer where it's just a small nodule, it's located in one small area. Cure is an option, and is the expectation of treatment at that point. But unfortunately, once lung cancer is advanced, and what we're talking about in this instance is staging 3B, which means that the lung cancer has spread to other areas of the body. And when this occurs, unfortunately, often the lung cancer is no longer curable. But with some of these personalized gene-targeted therapies we discussed earlier, the cancer can often be treated and prevented from advancing or progressing for many, many years. So treatment can still be very effective, but unfortunately at that point, cure is often not possible.
Yeah, different times. All right, we're going to get final thoughts. I think Dr. Pike, are you still on the line?
I'm still here.
Excellent. Dr. Pike, first of all, thanks again for your great work in Great Bend. Any final thoughts from Great Bend?
I just want to reiterate my excitement to have a new CT scanner that's capable of the low-dose screening. I think that's going to be a game changer for patients and for the surrounding community that no longer have to travel to get the lung cancer screening done. And I look forward to helping them find cancer and treat it before it becomes a more severe problem.
All right, thank you. Dr. Hawkinson.
Yeah, I think very good, insightful questions about boosters, long COVID, all that today. We are waiting for more information from boosters. It seems like the biggest information will come probably in about 6 weeks or maybe in 4 weeks, sometime in September about that. So we're hoping for that, and we'll keep everybody updated.
All right. Dr. Murmas.
Well, hopefully I'm a testament today to the power of vaccination and getting boosted, and the fact that I'm doing okay and not feeling too bad. And hopefully that's a good example to those out there still wondering whether vaccination is right for them. That, you know, with vaccination, the majority of people are going to have mild symptoms that aren't that severe. And secondly, you know, we've talked a lot about lung cancer screening and the benefits of lung cancer screening, and hopefully this session has really cleared up any questions people had about that, helped people identify those that qualify for lung cancer screening, and how with this lung cancer screening we can help save lives. At the end of the day, smoking cessation is always still the way to go, and the number one way to avoid cancer, and hopefully then not have to worry about screening. So
Yeah, and thank you, and thanks for being on our program today. And we make you to Godspeed getting better quickly and feel good. We'll check in with you during the week and make sure COVID-19 is staying at bay. Dr. Castro.
Well, I just want to mention one other point that we haven't brought up about low-dose screening. Is the hope is that we can detect early stages of lung cancer. And there's actually a treatment trial that's going on here at KU Cancer Center where they're using an anti-cytokine therapy in early stage lung cancer to see if that can help prevent recurrence down the road. So there's a lot of advantages that coming to KU Cancer Center would give you that you would not have access elsewhere. And so I encourage you to go to that website and take a look at those trials and see if you could participate and, you know, still maintain your standard of care treatment with your oncologist, your lung cancer doctor, but still open up new doors of possibilities for you.
Yeah, that's a big deal. Hey, you know, Star Trek lost an icon this last week. Nichelle Nichols, who was Lieutenant Commander Uhura, Lieutenant Uhura, passed away after 89 years of life. She was an outstanding character. She was one of the first African-American women, if not the first, to hold a position of command and respect on a television show in the United States in the 1960s. She was a hero, and in many ways, what we're asking for all of you to do is also be a hero. Whether it's be to give testament about not smoking, following the rules of infection prevention and control, trying to keep our communities healthier and safer as we go through this pandemic, we need more heroes. We hope that we can all be like Star Trek and live long and prosper. Hey, tomorrow, it's been a year since we debuted the very first Open Mics with Dr. Stites. We're going to take you back to that first episode with guest Dr. Doug Girard, the chancellor at the University of Kansas. We'll see what our COVID numbers were like then compared to now. Will you see back live on Wednesday at 8? And remember, be a hero.
45,000 new cases of rectal cancer will be diagnosed this year, according to the American Cancer Society. On the next Open Mics, Dr. Stites shows us the science behind a new treatment that made rectal cancer disappear in acute patients. The remarkable research, Wednesday at 8.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.